So hello and welcome to the very first coast-to-coast town hall on patient privacy and information sharing of families experiencing mental illness. If I don't know you, my name is Faydra Aldridge, and I have the honor of working with an amazing team here in British Columbia with the BC Schizophrenia Society, otherwise known as BCSS. But before we get started, it is very important that we acknowledge that the lands that BCSS and FASMI support families on are on the traditional, ancestral, and unceded territories of the First Nations, Métis, and Inuit peoples. We are honored and privileged to live and work on this land that we all share. We are committed to reconciliation, decolonization, and learning both from and with Indigenous peoples and building relationships with Indigenous communities across our provinces. For those of you who are not familiar with the two organizations who have planned this event, here's just a little bit of a brief overview. Of course, there's lots more information on our websites, but here's an overview. So the BC Schizophrenia Society, as I mentioned earlier, is based here in British Columbia. We are a long-standing nonprofit organization. We were founded in 1982, so we've been around for, over 43 years now. And we provide support directly to families with a loved one with a severe and persistent mental illness. We provide education, and our mandate is to support families, specifically here in British Columbia. We increase awareness about severe mental illness, and we are incredibly grateful for our partnerships with the BC government, as well as other community organizations. FASMI stands for the Family Alliance for Severe Mental Illness. Their mission is to ensure that Canadians living with psychiatric illnesses receive timely and effective support. FASMI believes there must be suitable and easily accessible clinical services, supportive legislative framework, and families must be included as key stakeholders in clinical care and in system design and oversight. But before we get to our presenters, I just want to offer some context on this particular issue. The purpose of this town hall is to discuss patient privacy and how that relates to sharing information with families as a means to improving care. Now, most of us know who are on this call right now that primary care is the very first line of defense for treatment of mental illnesses. But there seems to be a large knowledge gap among some mental health professionals about the importance of including families with a loved one with a severe and persistent mental illness. We're constantly hearing about the importance of having family-centered care. But in psychiatric services, there seems to be a reluctance by some professionals to involve the family. Now, there are many psychiatrists who consistently do this, and they do bring in family members. So I don't want to generalize. But the psychiatrists that do this don't just do this because they want to. They do it because evidence clearly shows the importance and the impact of involving family members. There's the impact on the family members themselves. They provide support and assist with the continuity of care for their loved one as they shift from a psychiatric hospital to outpatient community services. They can help reduce the stigma surrounding mental illness since they are involved in the entire journey, as you know. They watch for signs of relapse, help maintain adherence to medication, decrease the need for frequent ER visits, and potentially, if appropriate, even provide housing. Family members can also directly assist the primary care team. They do this in a number of ways, helping them make the most appropriate medical decisions, finding the most appropriate psychosocial rehabilitation options at that time, helping reduce their workload by providing additional support, and assisting clinicians with the discharge process, follow-up appointments, and medication adherence. Third point, family members can also help reduce the economic burden on our healthcare system and decrease the need for paid formal services. In fact, in 1999, so I realize it's a long time ago, The Mental Health Commission of Canada provided an estimate of how much family caregivers save the health and social system, which was over $12 billion a year. And that was 26 years ago. So you can just imagine what that number would be today. So why does this knowledge gap exist? Well, there's really no clear answer, but here's some of the reasons that we hear. Number one, that some clinicians don't want to involve or upset family members or cause them extra stress during this difficult time. Number two, clinicians are overworked. So involving additional people just means more work and will add on to their already very busy workload. Number three, that some clinicians believe that confidentiality laws preclude them from giving this information because the patient has not consented to it. But the legislation in most provinces will allow it as long as it is in the best interest of the patient and the family. So as we all know, legal and professional ethics require that doctors, nurses, and other clinicians keep everything that a patient tells them confidential, except where the patient gives permission or consent to release information, or where the law allows or requires information sharing with others, even if that individual does not consent. Legislation varies from province to province, and I wish we had time to go through the various legislation because I think it would be really helpful information, but unfortunately, we don't have time to get into all of the differences. So what we're going to do instead is to include the information in the chat box. So please, when you have a moment, maybe at bedtime tonight, please go into the chat box and read all about the differences in the legislation across our country. It is very informative and it's important information. But the key is that we are united. It doesn't matter where we live, we are united. And now we get to hear from our very first speaker. I have the great honor of introducing you to Cyndi and Dennis Corbett. They live in Nova Scotia. So Cyndi and Dennis, I'm handing the virtual microphone over to you. Take it away.
Good evening from the East Coast in Nova Scotia, and also good afternoon to everyone in the West. We are here today to tell you our son's story from our perspective as his parents. For us and for his sister, the acute psychotic episode that took him to hospital was a deeply traumatic event in the story of our family. We felt completely helpless when he was living on the streets in such a vulnerable state. And we also felt a tremendous amount of guilt that we didn't know how extremely ill he was. Our son's illness has taken our family to some very dark places, places that we did not want to go to, and nor did we have the skills to navigate. Through much of it, though, like many of you, we have been on our own as parents. But as one of my favorite quotes, which you can see on the slide, says, and this is truly why we're in it, is for our loved ones, caregiving often calls us to lean into a love that we didn't know was possible. People with serious mental illness are some of the loneliest, lost souls in society. And we feel that by default, as families, we too are lonely and lost in caring.
Our son moved to BC after high school, and he did a variety of short-term jobs to make ends meet. We tried to keep in contact, but he was always on the move. And sometimes we would lose contact for periods of time. We now know that during these times, he was very unwell and sometimes unaware of how ill he was. He has since told us that he was too ashamed. To reach out to us for help. But schizophrenia has a way of surfacing eventually, and it often does in a crisis.
So 3 years ago, when our son was still living in Vancouver, he had an acute psychotic episode that sent him to hospital involuntarily under the BC Mental Health Act. Although he couldn't see it at the time, he now says that being taken to hospital saved his life. And we feel that way too. The psychiatrist who phoned us when he was first admitted tried to explain his illness to us, which at the time we knew virtually nothing about. We can still recall his words. He said, "Your son is very ill. If I were to describe it like a physical illness, it would be the equivalent of having cancer, heart disease, and diabetes all at once happening in the brain." That really stuck with us, and always has. Looking back, we know it was truly a miracle that our son finally landed in the hospital. But also there's a very sad reality to this. It's the fact that he had to become so very ill for most of his 20s, probably, before he could receive proper treatment and diagnosis.
Now, this story does have its blessings. There are so many things that in his severe psychotic state, he could have led to a much more tragic outcomes. We have learned to be thankful for all the things that led to saving our son's life. The first of them being that he was taken to the hospital. He was able to remember our phone number. At this point, he had lost his phone, all of his ID, and all his possessions. He was evicted from his apartment. He was on the street. But he was also able to give us full consent. And in his words, he said, "If it hadn't been for my involuntary admittance and my insistence that my parents be part of my circle of care, I would be dead. I considered the option of suicide many times. By the grace of God, that didn't happen."
Our son spent 2 months in hospital, and he was properly medicated for the very first time in his life, and he received a diagnosis of schizophrenia. He was still very symptomatic when the BC medical team deemed him well enough to travel home with Dennis to Nova Scotia. And we were also very ill-equipped to take care of him at the time. Even though we had some skills from our former careers, I'm a retired teacher and Dennis is a former social worker, we'd have to say that navigating the mental health care system has been an absolutely mammoth task. Our son would not have been able to get himself the care he needed then, nor can he still get a lot of the things he needs now. We don't know truly how anyone can survive with this illness without an advocate. During our son's stay in hospital, we worked tirelessly to find services for him in Nova Scotia that we knew we would need when he came home. And for us at that time, everything was it's like a crash course, and all of it in crisis. It seemed to us, and still does, absolutely unbelievable that it could be so difficult for us to speak on behalf of our son, who was so very ill. We kept asking ourselves, how is a family supposed to do all the caring while being blocked from the vital information? On the slide, you can see a photo of the sea of notes, the contacts, and the information that was spread across our kitchen counter. I took this photo at the end of a particularly frustrating day of searching and sent it to my best friend, who was very concerned about our son and the situation we were in. And you can see her response, the quote. And so we thought, why should Dennis and I, or any parents for that matter, have to be detectives on top of being in the middle of a crisis and also so very traumatized and living with that about what happened?
But after much education, We now know that in psychosis, 50 to 80% of persons with schizophrenia experience a lack of insight of their condition. And of course, a lot of us know this term to be termed as anosognosia. Those in the middle of a psychotic episode are not able to make rational decisions, and they often will refuse help. Part of our son's delusion in psychosis was that the RCMP was conspiring against him. And he also thought that all the hospital staff and people who were trying to help him, they were just all actors. And, really, why would anybody have sought medical treatment in this state that he was in? So fast forward to today, 3 years later, many things have helped to change the trajectory of his life. He is fortunate to be a patient at the Nova Scotia Early Psychosis Program, where he has an expert medical team that specializes in serious mental illness and compassionate care. He also receives lots of support and love from his family.
His own words best capture the need for a trusted loved one to speak on behalf of the person experiencing the mental health crisis. He said, "I was entirely incapable of advocating for myself during the time that I was ill. I was in and out of a delusional state. At times, I was often even capable of convincing medical clinicians that I was fine. But inside, I was completely out of touch with reality. The key to my recovery has been in adhering to my medical team's advice and also to the advice of my parents." The solution for our family is and has been advocacy. As our sons recovered and became educated about his own illness, he could see that he had been very lucky to survive. He wanted to speak out about the important role of family intervening when he was not well enough to advocate for himself. I currently belong to an advocacy group called the Nova Scotia Mums. In the slide, our group is trying to get the attention of government outside the National Premiers Conference in 2024. Since then, the Nova Scotia Mums have been successful in lobbying government. It's been a lot of work, but an amendment to the Personal Health Information Act in Nova Scotia was passed last month, which will legislate increased ability for clinicians of those with serious mental illness to collaborate with their chosen families. But I'd like to note an important part here that the legislative change is really only step one. Our goal, which is will be much more of our work, is to educate within the mental health care system about the vital role family can play in supporting loved ones with serious mental illness. Our group feels strongly that we need a significant culture change in the system.
Now, you might think that this sounds like a pretty good recovery story. Up until now, very recently, our son has shared his personal story publicly and was committed to raising awareness about the lack of insight that occurs in psychosis. He was actually looking forward to speaking at this event tonight personally. But with his illness, it doesn't take much for things to change and change very quickly. Up until now, it's been a luxury for us to have our son's full consent and to collaborate with his medical team and to be involved in his day-to-day wellness. That includes many things, such as that we've always done for him, daily phone check-ins, appointments, reminders, emotional and financial support.
So currently his wife lives with bipolar disorder and she's currently very unwell. She decided due to a lot of paranoia as a symptom of her illness, to cut off all of our son's family support, including the communication with us. As a result of this, he has withdrawn from all public speaking, and now, as many that live with these illnesses, they are isolating. Our biggest concern is that without our support, which has been very integral to his well-being. We think it will now be a bit compromised. We're feeling the pain now of not being able to help, which is something that many families experience, and it is extremely painful. For us, this is a new part of the cycle of serious mental illness, and it's always a bit of a roller coaster, as you know. Thank you so much for listening to our story.
Thank you, Cyndi. Thank you, Dennis. Thanks for sharing your story and for sharing your son's message about the vital role that parents play. And I know you two have played a very important role in your son's life. And thank you for sharing your story with all of us across the country here tonight. Thank you to you both. And now up next, I get to introduce Bonnie Spence-Vinge. Bonnie is a regional manager. She's also a family member. So I have the honor of working with Bonnie. And Bonnie, I was going to introduce you, but I think I will just let you jump in and tell your story. So Bonnie, over to you.
Thank you very much, Faydra, and I appreciate the opportunity to be part of this important event this evening and to be able to share some stories of the families that I have the opportunity to work with in my position. And as you've indicated, I'm also a family member, and I deeply resonate with what was shared from the family previously, and I'm sure from what I'm going to hear from people who are calling in tonight. We have had some of the similar circumstances in terms of no access to information and the complications that come with that, and the difficulty then in our relationship with our loved ones because of that. So my work as a regional manager and educator for the BCSS provides me with the opportunity to support families who have loved ones living with mental illness and, unfortunately, increasingly often substance use disorder. Families reach out to us to learn about mental illness and to seek support in accessing care for their loved ones. We often hear from families that even though they are the primary caregivers, the mental health substance use service providers will not share information with them about the treatment and care planning for their loved one. The impact on the continuity of care for people living with mental illness can be therefore profound. And I would like to share a few examples from the families that I have the opportunity to support. In this instance, the person with living experience and their family received support and services both when involved with the early psychosis intervention program. But things changed dramatically after the client aged out. When they became a client with adult mental health and substance use services, the family no longer was provided any information about treatment, support plans, or behaviors to expect. Even though the local circle of care support network, which included the family, was in place most of this time, and the family was always the primary caregiver. At one point, the family wanted to share information about behavioral changes in their loved one, and they were told that their loved one would be advised about the source of this information. The family expressed concern about the impact this could have on their relationship with their loved one, but reluctantly agreed because they felt it was in the best interest of their loved one. As a result, estrangement occurred and continues. Another example. The person living with mental illness lived in a rural community, and the nearest mental health services were in a neighboring city. The family was not provided any information about what to expect in terms of behaviors or medication side effects. They were uncertain about how to manage the behavioral changes in their loved one. The mental health team did not provide the family, who were the primary caregivers, with the appointment schedule because the loved one did not give permission. Hence, we have a problem. How do we get to the community? The client did not drive or have access to other means of transportation, and as a result of which, appointments were missed and mental health supports were not provided. Another example. In this situation, the family member was not acknowledged as the caregiver by the mental health and substance use system and did not receive any information, again, about medication, treatments, appointments, or even names of staff designated as case managers. The reasons for this varied over time. Not the legal guardian was one reason given. Difficulty dealing with them as an advocate, another reason. And incorrect or incomplete consent paperwork by the client who was too ill to understand what they needed to be doing. The police did not have these concerns and worked cooperatively with the family member and with the client. The client missed appointments, receiving medication, missed assessments, and continued in psychosis and severe substance use. Another example. This person with living experience and the family members had a representation agreement in place, and a copy was provided to the psychiatrist. However, the family members had difficulty with the psychiatrist accepting information about behavioral concerns with their loved one. No information was shared with the family members about statements given to the psychiatrist that indicated self-harming behaviors of the loved one. The psychiatrist requested that the family members stop providing behavioral updates. However, the family continued to provide information when concerned, but did not receive any acknowledgement of receipt or any follow-up. Again, another family. The person was experiencing psychosis and was hospitalized after the family took them to the emergency unit. The family caregivers requested information on their status. The nurse they spoke to in the psychiatric unit refused to provide any information, stating patient confidentiality and not having a local circle of care document signed and in place yet. This was a smart family. They phoned back to the psychiatric unit and spoke to a different nurse who gave them information, but only as a for instance, stating that she understood their concerns and wanted to provide information, but did not want to get herself into trouble for sharing. Hence the for instance. Several families continue to express concern and frustration when the mental health hospital system assumes that their loved ones will be cared for at home, and when they're not given any information about what to expect in terms of behaviors related to the illness or medication side effects. At the BCSS, we help families to understand the current FOIPOP, Freedom of Information Protection of Privacy legislation, and how it can be used to create a collaborative relationship with themselves, their loved one, and the mental health and substance use system providers in order to maintain continuity of care, in order to help their loved one move forward in recovery, in order to maintain healthy relationships within the family. It's critical that the mental health substance use systems do the same with their own staff. And I would agree completely with the family that you just heard speak, that there is the opportunity for this to happen, but the culture is not there. And it's wrong that we have to rely on finding the right person in the system who will work with us, as opposed to it being a general practice of the system to work with families. Thank you.
I thoroughly enjoy working with you, and thank you so much for sharing the voices of family members that we hear. And those were some of the examples, but we hear many more examples like that from other family members. So thank you for being their voice, Bonnie. And now I have the pleasure of passing the microphone over to Dr. Richard O'Reilly. Dr. O'Reilly is based in London, Ontario. And Richard, I know we've all been anxiously waiting to hear from you, so please take the virtual microphone. Over to you.
Thanks very much, Ms. Aldridge, and thanks for everybody for coming out tonight, this afternoon, I guess, in BC. So my presentation is talking about why clinicians fail to speak with families, the things we've heard already. And I'm going to start with a story. I think it's useful to sort of tell a story that sort of sums up the problem. And it's a true story. It's actually a conglomerate of different stories. but you'll certainly get the message. So it's 3:30 on a Friday afternoon on 2 South in the hospital that I work on, and I'm checking medical orders for my patients to make sure that everything's set up for the weekend. And in the ward, I hear the phone ring, and the nurse picks up the phone. We'll say the nurse is a female nurse. Most of our nurses still are females. And she says, good afternoon, very politely. It's 2 South. And there's a silence, and eventually the nurse speaks again. I can only hear the nurse, and she says, yes, Miss Smith, yes, your son has been admitted to the ward, but I'm not able to give you any information. So more or less the same issues as we're hearing or we've heard in Bonnie Spence's presentation. But there's more silence, and the nurse says, "No, no, I can't tell you who your son's doctor is. No, I'm not able to. I'm not able to say that. Say that." And then she says, "Sorry again," and goodbye, and puts down the phone. So, I mean, I've heard this conversation or ones like it so many times, and I've also heard the problems in other parts of the hospital, in the emergency room, getting or giving information, and problems when patients are being discharged, families not knowing. But let's look at this simple example. The nurse is called, and she says, "No, I can't answer that question because of confidentiality." What else could that nurse have done? So she could have actually said, "Hold on, Mrs. Smith, I'm just going to go down to talk to John and see if he'll give permission for me to give you that information." Or if she was busy, she could have said, "I'm just dealing with another doctor now who's trying to get his orders ready for the weekend. And when I've finished with that, I'll get back to you." And in that time, she could have asked the patient if it would have been okay to speak with the parent. And the nurse, of course, if the patient, we'll call him John says, "No, I don't want you to talk to my mother," the nurse could have said, "Well, John, I think your mother only really wants to know that you're okay after the overdose you took last night, and that you've seen the doctor, and that Dr. Riley's started you on some new medication." So, John might say, "Well, that's fine, okay, as long as you don't say anything else, that's fine." So she could have encouraged him, and that would be, extremely reasonable and important if John was living at home with parents, as we've heard tonight already. So note that this is not an issue with privacy legislation. It's really a clinical issue, an issue in the relationship between the nurse, who's the representative of the clinical team, and the patient's family. Um, However, it's an issue, a problem that's pervasive and runs through the culture of mental health services and of mental health service providers, also known as clinicians. Um, and this is occurring even though we know, as Ms. Aldridge has pointed out already, that people who suffer from serious mental illness have better outcomes when families involved. So, so that's this is a real problem. Now, here's an important thing that's I want to say to you. In my opinion, the privacy legislation across Canada is reasonably adequate for the purposes that it's designed for. And they're really to protect the privacy of our healthcare information. So the healthcare information of all of us, including people that are on this call, that's what the legislation is here to protect. But also, another purpose is to allow clinicians to breach that duty of confidentiality in certain situations. Now, for sure, it's the legislation might be improved by changing wording here and there in some of our provincial and territorial acts. But clinicians don't use the current legislation, which is, in my view, reasonably permissive to share information appropriately with families. So, as Cyndi and Dennis, I think, have already pointed out, changing a few words in legislation without changing the culture will not rectify this situation. So I thank Ms. Aldridge. She gave a very brief overview of the legislation. I'm going to say a few words more. Dr. John Gray, who the British Columbia audience certainly will be familiar with, worked with me over the last year or so to summarize the legislation. And we have written that out in 3 documents, which are available on the main page of the FASMI website. So that's FASMI.ca, FASMI.ca. If you Google FASMI, our website comes up first. So one of those documents gives the breakdown of the key clauses in each jurisdiction based on, so you go jurisdiction by jurisdiction and what are the important clauses in privacy legislation. And it's very easy to go through this document. We start in British Columbia. So unlike the elections, British Columbians get to go first here, and then we move eastward across the country. And what are those key issues? Well, one is the collection of information without consent. So under what circumstances can clinicians talk to families to collect information? Then disclosing information without consent. Then the capacity to consent or to the disclosure or withholding of information. And then issues around what Bonnie brought up, keeping the source of information confidential. When are clinicians allowed to do that? So I'm just going to briefly talk about the first 3. So all Canadian jurisdictions allow clinicians to contact people apart from the patient, him or herself, to collect information when that information is needed for clinical care and it is not possible to get the information in a timely fashion from the patient, or it's not possible to obtain accurate information from the patient. So that's when clinicians can obtain information without consent. All Canadian jurisdictions allow clinicians to provide information to others to prevent serious harm. So if there's a risk of serious harm, clinicians can provide information. And serious harm is defined differently in different jurisdictions. I think it's really important people read that part of the legislation and say it's too restrictive, but it's specifically to prevent harm occurring to others. And it actually legalizes what is already in the common law. And then finally, most jurisdictions, BC being one of the notable exceptions, recognizes in legislation that adult patients may be incapable of consenting to the release or incapable of preventing the release of their healthcare information. And those jurisdictions then have a system to deal with that, to allow information to be released where necessary. So if this legislation is there, why do clinicians regularly fail to use these provisions to appropriately collect and disclose information? So I want to start with a positive one. It sounds a bit like an excuse, but I think it's important for this group to keep it in mind because we can easily get indignant, and I think there's all sorts of reasons to be indignant, but it's important to understand the clinician's perspective. So I'm going to really emphasize how important it is to keep information confidential between a doctor and a patient. That's the sort of starting point. And then exceptions have to be well defined. And this shouldn't be just dismissed. And it's especially important in psychiatry, where patients often share highly personal information with clinicians. So, even in situations where the law allows a psychiatrist to share information, that psychiatrist may decide that such approach would damage the doctor-patient relationship and not be the appropriate course of action. So the doctor may prioritize his or her relationship with the patient over sharing information, even though that's allowed. And that might be appropriate because the patient eventually has to cooperate with care, etc., and you have to establish an understanding to do that. However, I'm immediately going to say that this is not the majority of the cases. It's a small minority of cases. So what are the other reasons? Well, Ms. Aldridge has already touched on some of them. One clearly is ignorance. And I know this is going to surprise people, but many clinicians, including psychiatrists, are unaware of the provisions in their privacy legislation. I would estimate that, I don't know, 5% of psychiatrists have read their provincial legislation. And I can tell you, because I'm somebody who's interested in legislation, you got to read legislation over and over and over again to really understand it, really go back to it, discuss it with people, etc. So a lot of people, most people, really don't understand what's in the legislation. They're ignorant. And so then where do clinicians get their information? Well, clinicians almost exclusively hear messages from their superiors, clinical superiors in hospitals or agencies they work for. And I certainly do that. I get twice a year, I have to do an online course and an exam on this very topic. And it's all to like every single issue that's brought up is about situations where I'm prohibited from sharing information, not one where I must or should share information. Another reason, which again has been touched on tonight, is that it's time consuming to involve families in care. I know this is a practical issue. It's important, but it shouldn't be the primary driver of clinician behavior. But let me just give you an example. So if I'm a psychiatrist and I work in a private office but have patients in a hospital, I'll probably do ward rounds 3 times a week in the hospital, say Monday, Wednesday, Friday in the mornings. So if I have 8 patients in the hospital, it's really efficient to arrive at 10 o'clock. Nurses have those patients stay on the ward, and I just go room by room, taking whatever time I need, talking to them, writing orders, talking to the nursing staff, social worker, etc., getting the plan, and then off I go at the end of the time and do what other things I need to do. However, if I have to book 3 family sessions in that time, then I'm tied down, I'm anchored at different points, and there's going to be dead time, which I'm not able to use effectively, not get paid for, and that's a problem. So I'm not saying this is a good thing or it's that I support it, but it's one of the things you're going to deal with. But there still is an anti-family bias in our system. It goes back decades. We talked about in the past about the schizophrenic mother. More recently, people follow these things. There's a lot of issues about trauma in patients with psychosis and implications directly or covertly that this might be because of family issues. So again, families are seen as potential problem, part of the problem, not the solution. Finally, Canada and North America are incredibly individualistic societies. If you were in Italy or Spain or South America, any country in South America, you're highly unlikely to run up against these problems. Those cultures are much more family oriented. So I've got a couple of minutes left to talk about what can be done. And the last the first thing I have to tell you is that there's no easy answer. To change the culture, we really need to pressure professional colleges to get their members to follow the law. And then we need to convince the clinical teaching schools to emphasize the importance of including families and to emphasize the legal authority to do so in certain situations. And we must convince hospitals to deliver a more balanced message. So FASMI currently is working and will work with local groups in different provinces to do this. Everybody in this call can help by not accepting what's happening, by complaining when you encounter these barriers. So, for example, if you are the person on the other end of the call that I described right at the beginning of this talk, um, uh, um, and the nurse says, I can't tell you because of confidentiality, ask him or her, well, can you speak with John and ask him if he'll let you tell me how he is generally and what treatment he's getting? And if the nurse doesn't do this or doesn't get back to you, then write to the doctor who's involved at a hospital, even the CEO of the hospital, and ask if anyone has asked John's permission to speak with the family, and question if John is really competent to refuse if he didn't. Now, Ms. Aldridge has noted that the link to that FASMI website is in the chat, so that's good. But you can just Google it, and you can see there are 3 papers. I don't think I mentioned the second paper. There's a paper there, a backgrounder to sharing information, and that has the different elements done on the basis of topic, and I think would be an interesting article to read for anybody who's signed on to this website. The other thing, the final thing I want to say is that complaining can be done effectively, and it is effective if 2 or 3 people complain about the same thing to a hospital, and that being the psychiatrist in chief of a hospital, then the hospital will sit up and take note. So I have an online talk in which the latter part of it addresses how to do that. So that's if you Google Home on the Hill, Dr. O'Reilly, you should get that. But I think it also is going to be included in the chat. So thanks very much for your time.
Thank you so much, Dr. O'Reilly. There's lots of information there, and I'm sure people have a lot of questions for you. But before we get to you, Dr. O'Reilly, I want to ask a general question, and I see that there's already a lot of questions in the chat box, which is great. But the first question that I have here is for Cyndi and for Dennis. So first question, what do you wish more people understood about coping with schizophrenia and psychosis? So Cyndi and Dennis, if you could answer that question.
I think what we know now, 3 years later, compared to what we knew at the very beginning, I wish I had known. And we see so many people in the support groups where we work that are arriving in, like I said, in the talk, in crisis. These psychotic illnesses are extremely complex, and it requires, for us, it's required a lot of education, and which even has been a little bit a challenge to find. But things like I'm definitely currently advocating for LEAP training for parents in our province, and we can't seem to get that. I think it would be extremely beneficial as for any parent to have some of these skills, helpful in managing psychosis, and also motivational interviewing, which we sort of have researched ourselves, but we would like to have more information on that. Other things I think that are important, we took assist training. I think that should be available to parents, anybody that has psychotic illness, and because suicide's a reality. And there are just so many things that one has to learn to care properly for a loved one living with these illnesses. I don't know if you want to add.
Yeah, thanks, Ms. Aldridge, for that question. and there's an awful lot I could say on that question. I could go on forever. But I think one big takeaway that I would have is that despite, what the media portrays people living with severe mental illness, movies, TV shows, and the like, it's always so important to remember that even though, our loved ones may share a diagnosis, and with that, we have some overlap, some commonalities, but these are all individual people, and they all have individual dreams and hopes for the future. And that, we don't stigmatize them through what we see on TV.
Yeah, well said. Well said. And Dennis, I just have to bring up a point. You mentioned anosognosia when you and Cyndi were speaking, and I'm so glad that you brought that up, because if somebody does not recognize that they have an illness, why would they ask for help?
Yeah.
So I'm really glad you brought that up. And I think there's more and more awareness about anosognosia, but I still think we have a long way to go with the
Sure.
recognition that there are majority of individuals experiencing psychosis do not recognize that they are ill. So thanks again, Cyndi and Dennis, for bringing up that important topic and also talking about the stigma within the media. That's a big topic. And there's still so many myths, even in movies today, when it comes to schizophrenia. So thank you for bringing up those important points.
Thank you.
And just a reminder, if you have any questions for any of our panelists, please remember to click the Q&A button to enter your questions. And if you have a specific question for a specific person, please let us know. Bonnie, this one is for you. Why are families who have a loved one with a severe mental illness treated differently than those who have a relative with cancer or have been in a car accident or another physical illness?
Okay. I think families unfortunately experience that a lot, as does the person living with the illness. And I would say generally it's because of a lack of understanding about why people develop a mental illness and the fact that it actually is an illness and not a behavior of choice. We need a lot of public education around this. And because we don't have that, and people just see what's in the media, what they might see downtown in the East Side, Vancouver, other places, there's a lot of fear and stigma, and that comes from a lack of understanding and a lack of education, a lack of knowledge. And because it's invisible.
Mhm.
You look at the person, they just look like the rest of us, and yet they don't behave like the rest of us. And that causes people to be fearful and anxious. And when we don't know, we make up reasons for why we think that is happening.
Good answer.
Yeah.
Yeah. Fear.
Yeah.
And that's why events like this are so important for us to increase knowledge and get the
Right.
information out there.
Could I just add a little point? Because when we were
course.
speaking about anosognosia and you were talking about how people need to understand what that is, that includes people who work in the medical system. Because we've had a number of experiences here in British Columbia where families understand this and they're talking to somebody in the medical system about anosognosia, and it's a new term.
So Bonnie, what do you think, as somebody who works with families on a daily basis, what do you think we could do to increase information about anosognosia and get that information out there? What else could we do?
Well, there's a lot more public information we could be providing, all of the different agencies for sure. I think in our role as BCSS, it behooves us to ensure that our families really understand this and that they can then take that information forward when they're advocating on behalf of their loved one.
Okay, Dr. Riley, this one is for you. A doctor will disregard a patient's privacy when dealing with a person who has dementia because they understand that the person cannot take care of themselves and they do not understand that they are ill. Why do they not have the same code of behavior for clinicians with a person who has schizophrenia when it's obvious that the patient does not have a grasp on reality and they are unable to take care of themselves?
Well, that's a really good question. And, Ms. Aldridge, I don't have a clear answer for that question. Part of it, I would say, is that there's the patient with dementia typically is not able to express a desire not to have information shared. whereas some patients, many patients with mental illnesses of different types can do that. But as I said, I want to really emphasize it's often not at that level that you get the barrier. It's before that level where the patient isn't asked, is that okay? Is it okay that we share information?
So, Dr. Riley, how do we balance the need to respect an individual's need for privacy with what is in their best interests? How do we balance that?
So the So if somebody's independent and capable, so again, you do have the concept in law in British Columbia of capacity. It's just not with respect to sharing information. But if somebody doesn't understand what information needs to be shared, or what it's actually about, or what the consequences of them not having that information, then what's the consequences of somebody else not having the information, then they would lack capacity to make that decision, and somebody else would make it on their behalf. So that's clearly a situation in which information should be shared, even if the patient is saying, no, I don't want it to be shared. One of the interesting things it doesn't seem to have been taken into consideration in law or in clinical practice is dependency. And so I would suggest that that's a theme that's underlying a number of things we've heard tonight. So if somebody's living at home, the person you described right at the start, somebody, dependent on the family for lifts to get the medication from the pharmacy, to administer the medication, to monitor for side effects, etc. So dependency is a very big part of this. And similarly for children, I'm not convinced of the treatment capacity issues for children who live and are totally dependent on their parents. They may intellectually be able to understand things and even to have some appreciation, but they're still dependent on their parents, and to have their parents totally excluded from decision making seems problematic. That's the way I'd put it.
Yeah, thank you. And Dr. Riley, one more question. This isn't, but this is a question that I have because we do hear this from a lot of families. How do we address the situation where an individual experiencing psychosis does not recognize their parents, or because of their delusions, do not want to recognize their caregivers as their caregivers and don't want them being involved in their care, treatment planning? How do we deal with those issues?
So, again, I think the circumstances become important. If the person's come from home, has been living with the parents and is going back to the parents, I mean, that's one set of circumstances which would, it's how are we going to do this? We said, like, if people don't know what the medication is or what the side effects are, then that's a huge problem. Some people are even with severe psychosis aren't living with the parents. They may be living on their own with support from, I don't know, an ACT team or even friends, or they may be living in some type of residential supported care. And so, then the question about whether parents need to know or should know, it becomes a different question.
Thank you.
I'm not saying that parents shouldn't be given any information on that or all of it, but I think that the discussion, the considerations are different.
Perfect. Thank you. Okay, this one is for Bonnie.
Mm.
The comment is, this is an extremely powerful and unique resource documenting problems that are obviously widespread across our country. Should be widely distributed to all mental health service providers, and it should be used as a teaching tool in programs training nurses, psychiatrists, occupational therapists, paratherapists, and others providing mental health services. How do we make this happen? the million-dollar question, Bonnie.
It is. Thank you for asking me particularly, rather than anyone else on the panel. We have grappled with this as an organization for a very, very long time. And getting the ear of the people in across those high-level organizations is the first place what we need to go. In British Columbia, what we are currently doing is we are doing presentations, education presentations, partnership presentations, wherever we have the opportunity to those organizations. As an example, Faydra and I and a family and a person with living experience recently did a presentation at the local college here for nursing students. We are doing another one for education students. But these are people, it only addresses part of what is being raised here. We have to get to the next level up because we're coming in to do a presentation. We're not really part of the curriculum. And when these people become members of a professional college, there are practices that they have to adhere to as members, their expectations about behavior. So we need to reach out to those groups. I believe we have to start at the top end and try and find a way to engage those people first before we do the grassroots piece, because the grassroots people may have an understanding, may be sympathetic, and yet once they get out in the world to practice, they have supervisors, they have managers, they have systems, as Richard has pointed out. They work for an organization that has a culture, that has a set of practices that they have to adhere to, regardless of their potentially personal point of view on all of this. So if I had the solution about what we would do, you'd sit them all down in a room and say, listen to these stories, and this is the research to support it. Now, what are you going to do to support this yourself, to make it easier for your people that you hire to do their jobs effectively and help more people move forward into recovery?
And that's why, Bonnie, you were asked that question.
Yeah, okay.
I completely agree with you. And, I think as an organizations, both BCSS and FASMI, I think we play a very important role with education and continuing to increase information and knowledge about that. So thank you, Bonnie.
Mm-hmm.
Dr. O'Reilly, I know you touched on this question before, but you have a specific question. How do I get a doctor to share information with me if he said my son will not consent?
So if I'm sitting in the relatives chair, the parents chair, I guess, I would say, well, check, have you asked him? Have you tried to convince him? Have you explained to him what information specifically you want to share? I mean, have you said, look, all your parents want to know is what medication and to learn a little bit about the side effects of that medication and maybe early symptoms of relapse. Let's say the doctor says, yeah, I've done all those things, and he still says no. Say, well, what about suggesting that we meet together, and so that any information that's shared, he could actually observe and step in if he didn't want that. And this is something that's worked often for me, to say to the patient, well, you're a bit concerned about this and that, and you don't want your parents saying certain things. But we could meet together, and if you're uncomfortable about anything, speak up, and that often works well. So there are a variety of things that can be done. But at the end of the day, comes the question of, is my son capable of saying that information should not be distributed? And so that test is a general test across the country. The ability to understand the task, sharing the information, what that consists of, but the key bit for people with psychosis, the ability to understand the consequences of refusing to share the information, sharing it or refusing to share it. And so for some people, it's quite clear that they do not understand the consequences of refusing to share the information.
And that ties into what Cyndi and Dennis said earlier about their son and using their son's voice to share just the important role. And that Cyndi and Dennis, as you said, your son wouldn't be here if it wasn't for you two advocating and for him recognizing the important role that you've played. So, yeah, thank you for that, Dr. O'Reilly. And here's another segue, a nice segue into the next question for you again, Dr. O'Reilly. How can clinicians expect families to support their loved one when they are not privy to information? Many families express concern about taking their loved one home when they have no information, and how scared that they can be to bring their loved one home for the first time.
Yeah, well, there's not really an answer to that question. This is a ridiculous situation. So maybe I'll just take this opportunity to say that there's been well over 100 people on this call, and so one of the things I hope has happened is that some people have come to the realization that they're not alone, that this is happening to other people. It's not only happening in British Columbia, it's happening in Ontario and Nova Scotia, right across the prairies. This is happening everywhere. And it's ridiculous. The very situation you describe, to me, is I'll call myself a seasoned clinician, meaning an older clinician's been around. This has become progressively worse, and it's crazy to ask families to take someone home and not give them the information they need to look after that. What's happened with deinstitutionalization, with the closure of the large freestanding hospitals, is that families have taken on a lot of the roles, including providing financial support, but also clinical support, being case managers, de facto case managers, and so they must get that information.
Yeah, thank you.
Mhm.
Now, you've talked about this, Dr. O'Reilly, and we talked about this earlier. We know that there's a lot of demands on clinicians. So with these time constraints, what are your recommendations where we could address the time constraints on the clinicians, but also ensure that family members are getting the information that they need?
So I think clinical care should strive for excellence, and time constraints are a practical thing. I'm not excusing. In fact, I don't excuse this. It's always going to be a practical issue there. But the message should be that involving families is best practice, and in all areas of medicine, we should provide the best practice, evidence-based care. And if you're not doing that, you're failing in that regard. And hospitals should be badgered until they ensure that happens.
Dr. O'Reilly, I have to ask this question. What makes you so different than so many other clinicians? As you said, you believe that only 5% of clinicians actually actively involve family members. How did you get to the point where you're at to be able to speak so openly about this issue? And I know you speak regularly on this topic. So how did you get to this point? I'm curious about this one.
Well, first let me say about my colleagues, like I have many wonderful colleagues out there, including in British Columbia. I mean, I could start naming them off in British Columbia. They're wonderful. They're dedicated. They work harder than me. They're great. They're great people. I have an interest in legislation, so that's one thing. It's been an academic interest of mine. I've published widely on it. I'm confident about. I know what the legislation says and means, and how it can be used. I've also, personally, one of the reasons is I spent 20 years, I think, providing biannual, twice annual, no confusion, a presentation to families, and this issue always came up. So it was on the Mental Health Act, but this issue of sharing information come up at every one of those sessions. So, 40 sessions and hearing people time after time, it was predictable. So
Thank you.
yeah, so something has to be done.
And as you said, the purpose of this town hall is just to remind us all that it doesn't matter where we live, that it is a common concern and something that is brought up regularly by families. So thank you. Okay, Cyndi Dennis, you're up next. So the comment is, as a national voice, what can we do to really be heard? To hear the same experiences as a family across the country, what do we do and how can we demand change? The federal government under mental health rights or provinces, the need for wraparound supports, is that the answer? And can we speak as one voice and to who? Now, I know there's a lot of questions in there, Cyndi and Dennis, but just curious if you have any comments. So the biggest question summary is just, as a national voice, what can we do to be heard? And based on your experience, how can we better speak as one voice?
Well, I first of all should thank FASMI from the Nova Scotia mom's point of view, is that they've given us a lot of support. And I would say that we have to, the awareness has to be raised first. This is so true what Dr. O'Reilly had just spoken about. Any support group we've attended, any education sessions we've attended, one-to-one peer support sessions that we do, consent comes up all the time. It's the number one concern. And families are suffering as a result of not having consent, because particularly families that I've talked to, many adult children living at home I've had some that have been living at home for like 10 years. And because there's no consent, there's no financial support, there's no ability for them to ever have a say in their loved one's wellness. And yet, as you said, they're living in their home. So that's I don't know if you have anything else to say. I think really everyone, the voices are small and in pockets in our province anyway. And I think as having a national voice behind us is very helpful. And I think given the mental health crisis and the amount of money that families are actually saving, our governments, don't we deserve more support? So I think if we had the support as families, we would begin to increase our voice, I think.
Thank you,
I
Cyndi.
think it's also important that, having town halls just like this, and that everyone in attendance here tonight go back to their homes, go back to their communities, and talk to their groups, talk to other family members, and become actively involved. Become members of whatever group they have in their community, or national groups like FASMI, and join up so that all the voices can be heard.
Yeah.
It has to start small to get large.
Well said. Yeah, well said. Richard, I have, here's another question, Dr. O'Reilly. It's a competency question. So Dr. O'Reilly, what do you think is the next step when it comes to competency testing to make rational choices? How do we, so the healthcare providers are refusing to do so. Do we tell parents to get a lawyer, or how do we address the competency testing with families?
So I think asking the clinician, is my sister, husband, father, whatever, capable of making this decision? And this could be the decision to withhold information. It also could be the decision to refuse treatment. So I think that's the important one. I think I can't see the questioner, but I think they're saying, look, this is probably a fairly cut and dried situation where somebody's incapable, and the clinician is saying no. And in that situation, I would write a letter first to the clinician saying, you said that when we met you that Peter was capable, and then says, Peter says he doesn't have an illness. Peter says that when he takes the medication, he may get raped by Martians, whatever it is, put all that down and say, sure, does this not suggest or in fact clearly indicate that Peter is incapable? And put the clinician on the spot. And if you don't get the desired results, like a reversal of or sensible response, go to the next level, which would be the psychiatrist in chief of the hospital, and say, you keep all the records. I wrote to Dr. Riley on the 5th of March, he didn't get back to me. I wrote again, and so I'm now sending the first letter to you because I'd like an answer to this. And I'm sort of saying that out a little bit at length because that's the nature of the how to complain. I think it goes through the steps.
Okay, thank you. No, that makes sense. Thank you. There's been quite a few questions in regards to housing, and I think housing is something, even though that FASMI and BCSS do not provide the bricks and mortar, it is something that affects all of us. So this question is for you, Dr. Riley. When will the Canadian government start building proper supportive housing for those with severe mental illnesses? I'm a frontline worker of 4 years, and most of the unhoused population has schizophrenia, and these are the people left on the streets and treated like animals. I feel this goes against every basic human rights. Why is this being ignored for so long?
So, first, just let me say that I agree with the questioner entirely. This is a huge problem. And it's the end consequence of the institutionalization. So we didn't see this problem early in the institutionalization because when we now have about 34 beds per 100,000 per capita. Uh, when it was 50 beds, we had some people with severe illness in the community, and some weren't getting great treatment, but they were housed. But when our hospital lost its last 200 beds, we ran into a huge problem with what the hospital called euphemistically our legacy population. And so these were people that couldn't be placed in a Canadian Mental Health Association home, other regulated homes. We have a system here in Ontario, couldn't survive in long-term care, couldn't survive in unregulated homes, private unregulated. And it was the same behaviors. I'll not go through them. So we need a completely new type of residence, which is 24-hour nursing care, small, maybe 25 people, locked at night so that drug dealers can't get in and that people can't wander off into snowstorms. Doctors visiting probably, twice a week, both medical and psychiatric care. So very intense. We have not even contemplated this yet. So we have to convince provincial governments to start wrapping their mind around what would it take to house these people with psychosis, which represent about 20 to 25% of our homelessness here in Canada. What would it take to house them?
Yeah.
So
Yeah.
that conversation hasn't started. So that's what we need to get that conversation started.
Can you speak about clinicians' assessment of capacity of the patient? How does a clinician determine capacity? Are they taking the capacity assessment into consideration when not involving family members?
So there's two questions.
Yeah, there's a few questions in there. Yeah.
I did I'll just go with the last one. So in general, no. So when the issue of families not being involved is complicated, it's historical, it's to do with bias, it's to do with not only the physician's bias, but system bias, etc., against hospital and practical issues that I've talked about. The capacity, so to move to how do clinicians do capacity assessment? You know, it's a legal question. This is a legal question. You know, does the person have capacity? Do they have the ability to understand the task at hand? So accepting or rejecting medication, allowing the transmission, allowing the parents to hear about their mental health, get the information, or withholding that information. So do they have the ability to understand the issue at hand and the ability to appreciate the consequences? I've said it before, but that's the test. So that's what you assess, and you assess that by asking questions, Socratic analysis, like what would happen now if your parents weren't? Would they know what medication you're on? How would they know about side effects from that medication? So what would they do in this situation? Analyze what the person's understanding and ability to appreciate. So the ability bit is you've got to try to educate them. But when somebody has anosognosia, you can't do that. Because that's a definite no. I'm not ill. I'm fine.
Yeah, I'm not sick. I'm
I'm
fine.
not sick. I'm not sick. And other people, and it might be my parents are doubles. They're not my parents. They disappeared years ago.
Bonnie, I'm curious, as somebody who works with family members all the time, what message do you give family members when they are asking the same type of questions that we're addressing here tonight? What words of advice, what tips, what message do you give family members that are experiencing this for the first time or just beginning their journey?
Okay. Yes, it's a good question. I'm sure that Cyndi and Dennis could answer it equally well, and Richard too. What we do, first of all, is we try and give people as much education as we can to develop their understanding of the illness, everything to do with the illness. That's what Strengthening Families Together education programs is about, and we really encourage that. We encourage them to seek support for themselves through family support groups, peer support, whatever it is. We work with them on communication, like LEAP, so that they have better communication with their loved one and better communication with the system. We want them to understand the system. Even if they don't like the system, even if we don't think it's a functional system, you definitely need to understand how it works. That's really, really important for people. And then we teach them how to advocate, right? We teach tricks to people. Like I was listening to the example about housing. One of the things we've done with some families, and they've chosen to do, and we've supported it, and it's worked for some, is with this issue of discharge to the family home, is for the family to say, look, we can't bring them home because we don't know what we're dealing with. So we need information in order to make this work. And if you're not able to provide the information, then we are not able to provide a safe place for our loved one. That kind of stuff with people. How to share information. You email it, you text it, you drop it off in a letter, you confirm that it's been received. Lots of that kind of stuff. Families need to feel empowered, and the only way to do that is to continue to provide that they become experts. And they are actually the expert on their person, but now they become an expert on mental illness relative to their person. And that's what is really, really important. And to know that their voice is important for people to listen to, because they often feel cowed and overwhelmed and less than. They feel guilty, they feel responsible. And sometimes the mental health profession doesn't help change that feeling. So that's what we do. And I can see with Cyndi and Dennis that's where they are. Good for them. Good for your son.
Yeah. Thank you, Bonnie. Thank you for that response. Now, there was a lot of information in that Q&A session. So if there was a question that we didn't get to, please feel free to email us. Once again, the FASMI website is fasmi.ca and BCSS is bcss.org. We are recording this session, and it will be on both of the websites. So please do not hesitate to refer back to it and contact us if your question was not answered today. So with all this information that we just heard, what can we do? What can we do to change the culture that both Dr. O'Reilly and Bonnie and Cyndi and Dennis talked about tonight? Here's some ideas, and Dr. O'Reilly mentioned them as well. But just to recap, a greater emphasis on training around the importance of family involvement, including new psychiatrists, increased inclusion of family caregivers in the development of mental health policies so families can be seen as allies. Ensure that frontline care teams have sufficient and current training around legislation. Address the outdated family blaming, as we talked about earlier, which remains prevalent today. There's still a lot of mother blaming on childhood trauma. We have got to change that. And through events like this, we have got to keep talking about this important issue. And this issue is uniting us across the country. And we have to stay connected. And as mentioned earlier, we can stay connected through our newsletters, through our websites. And once again, that's FASMI.ca and BCSS.org. And just a heads up, this winter, the topic of privacy and family information sharing is going to be a podcast episode. And if you are interested, BCSS does host a podcast, and it's called Look Again, Mental Illness Reexamined. It's on anywhere you get podcasts. And later on this week, BCSS will be emailing you a very brief survey. We want to hear from you. We want to hear if this town hall was effective, if it answered your questions. Maybe even we look at a topic for another town hall. So please do not hesitate to let us know your feedback on today's event, what worked, areas we can improve on, and topics that we may want to consider in the future. We really do want to hear it from you. And please feel free to share this recording within your networks. And as I said earlier, don't hesitate to reach out to us. So to wrap up, evidence consistently shows the benefits of family involvement on the individual with the illness, our overworked clinicians, and on our healthcare system overall. And we have got to keep finding ways to bridge this gap, to bridge the gap that we were talking about tonight, and to find ways for health professionals and family members to build a stronger circle of care, to increase the trust for those that are treating individuals with a mental illness, for the family members, and of course, for the individual with the mental illness. Families, if you are a family member and you are on this call right now, you play such an important role. Your courage, your ability to be able to speak up, it is not easy being a family member of a loved one with a severe mental illness. But I am so glad you are on this call today. Cyndi and Dennis, thank you for your courage in sharing your story. Bonnie, thank you for being a part of BCSS and being a very active family member. And Dr. O'Reilly, thank you for being a very special clinician who continues to advocate, who continues to unite us across this country, and continues to talk about this very important issue. And I really do hope that we will continue to see change. And I think all of you being here tonight are an example that we're headed in the right direction. And to your audience, thank you for being here. We really didn't know how many people were going to show up for this town hall, but you've proven that this is a very important topic and we have to continue talking about it. So to our panelists, to the people who are on this call, and to all of you as caregivers, thank you for being here. And please fill out the survey. We really do want to hear from you. Stay connected, and we will see you soon. Thank you again for being here and for all that you do. Take care. Bye-bye.